Good morning, good afternoon, everybody. Wanted to welcome you to the Clinical Technical Assistance Office Hours. And I'm David Montecalvo. I'm with the Substance Use Warm Line at the National Clinician Consultation Center. I wanted to let you know that we are recording this session. And please feel free to drop any questions in the chat and we'll answer them at the end. Now it's my pleasure to introduce Laura Chauso with the Bureau of Primary Healthcare to kick us off. Laura?
Thanks. Good morning. On the West Coast, which is where NCCC is. Good afternoon for those of you on the East Coast with me. Again, I'm Laura Chauso. I'm a data statistician with the Quality Division within the Office of Quality Improvement, within the Bureau of Primary Healthcare, here at HRSA Health Resources and Service Administration, which is a mouthful and you don't need to remember that. It is a pleasure to make some introductory remarks today. We're really grateful to have NCCC prepare this webinar today on such an important topic, especially at a time when I know we are all seeing a lot more of this and yet seeing less of patients in person. The Bureau is committed to leveraging our strategic partners in delivering the latest information and promising practices in support of the work performed at our over 1,400 health centers. Before I turn it over to our presenter, I'd like to share some information about our health center program and some of the other resources we offer. Next slide, please. So in 2019, HRSA-funded health centers serve nearly 30 million people across the United States. That's 1 in 11 people in the US, 1 in 8 children, 1 in 5 rural residents, and 1 in 3 living in poverty. They provide affordable, comprehensive, quality, patient-centered care through a range of services and reach out to almost 400,000 veterans, over 1 million agricultural workers, and over 1.4 million people who are experiencing homelessness. Next slide, please. This slide shows the commitment the Bureau has made in addressing substance use disorder and behavioral health care services at our health centers. In 2019, more than 97% of health centers provided mental health services, and over 325,000 patients received substance use disorder services with over 1.8 million clinic visits. And from 2017 to 2019, there's been a 121% increase in patients receiving medication-assisted treatment. And in 2019, so before COVID, 32% of health centers provided telehealth for substance use disorder services. In addition to this webinar and the warm line, which is going to be talked about a bit more, HRSA is also working with JBS International to provide training and technical assistance to health centers working on behavioral health integration. There's going to be a webinar detailing the services on November 4th at 3 p.m. Eastern. And HRSA also has a SUD and primary care integration website, which provides resources and ways to request assistance. Next slide. Another resource for health centers interested in working on substance use disorders is the Safest Choice Learning Collaborative, which works with health centers to prevent fetal alcohol spectrum disorder and care for children affected by it. There are both prenatal and pediatric echoes, and for more information, please email Kendra Glute. Next slide. So before I hand it over, I just want to say that to note that the information provided today is intended as guidance to be used consistent with the internal needs of your organization. This information is not to be viewed as required by HRSA. We hope that you find it useful in supporting your health center's operation in addressing alcohol use disorder. I'll now turn it over to David, who will introduce our guest presenter.
Thank you so much, Laura. Next, I'd like to introduce our speaker, Dr. Trevani DeFries from the University of California, San Francisco. Thanks so much, Trevani, and you can kick us off. Thank you, Dr. Please.
Hello, everybody, and welcome to our presentation on the management of alcohol use disorder. I'm Trevini from UCSF and San Francisco General Hospital, and I'm a clinician consultant on the substance use swarm line. This webinar content was developed in part based on the types of calls coming through the substance use swarm line, and in it, we've really tried to address new challenges brought on by COVID. So I hope you find this useful. I have no financial disclosures, and of note, I'll be discussing the off-label use of 3 different medications that I'll point out. Today, we'll cover how unhealthy alcohol use remains a growing public health issue in the US and how it poses challenges to the everyday practice of primary care. And we'll cover it in these 4 parts of the presentation. We hope that after today's presentation, you'll be able to more confidently define the spectrum of unhealthy alcohol use and compare therapeutic approaches, focusing on pharmacologic treatment options. And I'll discuss information on strategies for safely managing alcohol withdrawal, which is an especially important issue during the COVID-19 pandemic, as well as ways to decrease harms of alcohol use for our patients. So going right into part 1, unhealthy alcohol use. A very recent study that just came out found that excessive alcohol use was responsible for about 93,000 deaths and 2.7 million years life lost annually in the United States. So this means that an average of 255 Americans die from excessive drinking every day, shortening their lives by an average of 29 years. This exceeds deaths from opioid overdoses. And the prevalence of alcohol use is increasing, and it's especially affecting certain groups. Spillane and colleagues found a large increase in alcohol-induced deaths that have accelerated over the past few years among both men and women. And these authors conclude that reflecting on the consequences of alcohol-related morbidity and mortality through the age range, our findings document an urgent public health crisis calling for concerted public health action. They found noteworthy increases in deaths among women, American Indian and Alaska Native individuals, and younger age groups. And several other studies have shown that certain ethnic and racial minorities experience more negative consequences of unhealthy alcohol use. And as we are all well aware, people are experiencing increased stress during the COVID-19 pandemic. During late June, 40% of US adults reported struggling with mental health or substance use. And researchers have found that in a recent national survey, people consumed alcohol significantly more frequently in 2020 compared with 2019. So the implications of COVID clearly extend far beyond the virus itself. And this matters because unhealthy alcohol use is costly for individuals, for our healthcare system, and on a social level. When compared to all drugs, alcohol actually has ranked to be most harmful and causes harms to the user, indicated in blue here, as well as to others, which indicated in red. As primary care providers, we are all well aware of the widespread physical and psychosocial conditions that are linked with alcohol. And I want to emphasize how closely linked alcohol is to the most common primary care conditions we see, like hypertension, diabetes, depression, and cancer. And even if your patient has not directly experienced an alcohol use disorder, they may have been touched by one in their life. In fact, having a parent with substance use is the most common adverse childhood experience. And we know that this affects people's health in adulthood. So it makes sense that the possibility of unhealthy alcohol use should be routinely considered in primary care patients. But unhealthy alcohol use often goes undetected and has been referred to as the elephant in the exam room. Only 1 in 6 patients reports being asked about drinking. The United States Preventative Task Force has been recommending broad assessment of alcohol use since 1989. And recently in 2018, they issued a recommendation to incorporate routine screening for heavy alcohol use into primary care. Screening can include standardized self-administered questionnaires that ask, do you sometimes drink alcoholic beverages? And then move on to the single screening question, the sort of most helpful question to take away, which is, how many times in the past year have you had 5 for men or 4 for women or more drinks in a day? This question has good sensitivity and specificity for detecting unhealthy alcohol use in the US primary care setting. And if the patient's response is 1 or more, a more detailed instrument, such as the audit C here, is recommended. An evidence-based approach you may have heard of is SBIRT, which includes screening, brief intervention, and referral to treatment. And this structures many of the interventions taking place in our clinics. But even when alcohol use disorder is detected, there is a massive treatment gap. Less than 10% of patients with unhealthy alcohol use receive treatment. And despite the availability of effective medications, only about 50% of those treated receive pharmacotherapy. Medications for alcohol use disorder are safe and have been FDA approved for decades. They are not controlled medications, and they can be prescribed by any provider. They have few medication interactions. They can mostly be combined with each other, and they can be started and stopped without much titration compared to many of the other medications we prescribe. However, they remain vastly underprescribed. They've even been called the most underutilized medications in primary care. So with that, let's move on to the treatment of alcohol use disorder. Unhealthy alcohol use is a term I've been using, and it's the umbrella term for a spectrum of problematic drinking that spans from risky drinking on the left, or drinking above safer limits that are listed in this table, all the way to alcohol use disorder on the right, which is diagnosed by the DSM-5 criteria. When alcohol use leads to ongoing negative life consequences, such as in these domains listed here of impaired control, social impairment, risky use, and physiologic dependence, it becomes a disorder as defined by the DSM-5. Having 2 or more symptoms present in a 12-month period meets the criteria for an alcohol use disorder. And the more symptoms present, the greater the severity. The DSM-5 is easily Googleable and something that you can bring up online when you're discussing openly with a patient about their alcohol use. And for at-risk drinking, brief interventions delivered in a range of healthcare settings have been shown to be effective for reducing heavy drinking. Brief interventions consist of 10 to 15 minutes of counseling, raising the subject, giving feedback about drinking, goal setting, and defining close follow-up. But brief interventions alone have not been shown to be effective for patients with more severe alcohol use disorder, despite the fact that this is historically what most patients have received. Now, for those on the side of the spectrum with moderate to severe AUD, or alcohol use disorder, a medication plus a psychosocial intervention should be offered. So next, we'll discuss starting with the 3 FDA-approved medications for alcohol use disorder. A number of different clinical factors, including a patient's comorbidities, their specific goals, and their adherence, can affect the choice of medication that we ultimately use. The first medication that we'll discuss is naltrexone, and this can be considered the first-line medication. Naltrexone is a mu-opioid receptor antagonist that reduces the rewarding effects of alcohol on the brain. It has a number needed to treat of 20 to prevent return to any drinking and 12 to prevent return to heavy drinking. So it can be used both if someone is actively drinking and their personal goal is to cut back, or if somebody wants to maintain complete abstinence from alcohol. It comes in a daily oral form, as well as an injectable monthly intramuscular formulation, which may be a useful option for those that struggle with adherence to a daily pill. It's generally well tolerated, but rarely people do experience headache or nausea, which often subsides. The most common question, though, that comes up regarding medications for alcohol use disorder overall is about what to do with somebody who has liver disease and whether a person with liver disease can receive naltrexone. So you can use the Child's Pew score as a marker of liver compensation, and you can find these scores online. Avoid naltrexone if Child's Pew C or greater, or if the AST or ALT are around 200 or more. That's around 5 times the upper limit of normal. The other major limitation of naltrexone is that it cannot be used for people who are using opioids. People could experience precipitated withdrawal if they start naltrexone when opioids are in their system, so they need to be abstinent from opioids prior to initiation, usually on the order of about 7 days, but we can further discuss that. Once on naltrexone, opioids will not be effective for pain control, not be as effective for pain control. So in the case of an emergency, for example, that's something that a patient and their provider should be aware of. Patients could even consider carrying a card in their wallet that states that they're on naltrexone for this reason. Naltrexone and acamprosate are the most strongly supported by clinical trials. So next we'll talk about acamprosate. Its mechanism of action is related to helping people with the symptoms that they feel that are associated with often a subacute withdrawal. And it's been found to be most effective for patients who have a goal of abstinence, of complete abstinence. It's actually been found to be more effective when patients have a longer period of abstinence prior to initiating the medication. Big picture, acamprosate is recommended when a patient cannot receive naltrexone due to liver impairment or because they're on opioids. The major con of acamprosate, though, is that it's 2 pills 3 times a day. So it's a high pill burden. And it requires renal dosing for people with a decreased creatinine clearance. The last FDA-approved medication is disulfiram. Drinking alcohol while taking disulfiram results in the accumulation of acetaldehyde and very unpleasant effects, even leading people to need to visit the emergency room. Because of this, disulfiram should only be used in a patient who has a strong goal of complete abstinence. Clinical trials suggest that disulfiram is only effective when the medication is taken routinely under supervised conditions, which could include at an opioid treatment program, a methadone clinic where they're going daily, or with a close family member who may be helping to monitor and dose their medications. There are concerns of using disulfiram in the setting of pregnancy, severe mental illness, and liver impairment. Next, I'll discuss 3 medications that are used for alcohol use disorder, but are not FDA approved for this indication. And so they have more limited evidence. Topiramate is an anticonvulsant that has shown benefit in the treatment of AUD. It needs to be titrated up to 300 milligrams per day for this indication over about 8 weeks. And it's the only medication for AUD that should not be abruptly discontinued. It can be especially beneficial for people who have concurrent seizures, insomnia, or weight gain. And its main limitation, though, is its tolerability. It does have a significant number needed to harm, meaning it causes adverse effects on cognition, it can cause paresthesias, altered taste sensation, and sedation in patients. Gabapentin is another anticonvulsant, and it's one that many primary care providers are comfortable using. It's been studied at doses between 900 and 1800 milligrams per day for alcohol use disorder. And a recent study in the last year showed that it may be especially helpful in people who have a history of alcohol withdrawal symptoms, which can be useful because gabapentin can also be used as a medication for alcohol withdrawal itself, which we'll discuss. It does need to be dose adjusted for kidney impairment, and it might be helpful for those that have another indication for its use, like neuropathic pain. But gabapentin, as you've heard, has been the subject of some reported misuse, and so that is a small concern. Lastly, baclofen has been of interest because it does not have liver toxicity. But studies have not demonstrated consistent efficacy for baclofen. And in fact, a recent study showed significant harms that occurred in a dose-response relationship with baclofen, which does raise some concerns about its use. We finished going through the medications for alcohol use disorder. So here are the different psychosocial treatment options that have been studied for AUD. It's important to note that clinical trials have not found any one intervention to be superior to the others. Often, clinicians are most familiar with Alcoholics Anonymous, or AA, which is a 12-step program. A recent review appeared to report very broad effectiveness for AA, but it's important to point out that studies on AA have been limited. They've been limited by a significant risk of bias and have looked at AA primarily in conjunction with psychotherapy. So what we can conclude is that AA can help some people with alcohol use disorder, and there isn't necessarily the most solid evidence for its broad effectiveness across the board. During the COVID pandemic, many forms of psychosocial support have gone virtual. And this is really important because many patients really rely on the community that's offered by these recovery resources. There are a variety of online support groups, apps, and podcasts that patients can continue to engage in during COVID, and they can be linked to through these two resources or through an easy online search. So in summary, medications and psychosocial treatment options are at the core of treatment for alcohol use disorder. And we should leverage shared decision-making with the patient to help navigate the menu of options, elicit their own motivations through motivational interviewing, focus on their strengths, and ideally use a team approach that can provide frequent touch points and provide the close follow-up that patients need. Next, we'll discuss the topic of alcohol withdrawal management. We've received a number of questions about this from outpatient clinicians practicing during COVID. And the management is going to be very individualized to your specific patient and to the unique resources of your practice setting. But the goal here is to relay some helpful principles and tools. This topic, as I mentioned, has become ever more important during the COVID-19 pandemic, when people's isolation has increased and the supply of alcohol has been interrupted in many cases. This map from April shows how off-premise retail outlets or locations that legally sell alcohol were broadly closed, as indicated in blue. So consider the risk of alcohol withdrawal in this context. Patients with alcohol use disorder who stop drinking should be considered for medically supervised alcohol withdrawal, which is indicated for people with or at risk of withdrawal symptoms. Generally, as a general principle, those with mild to moderate symptoms and no history of seizures or delirium tremens can be managed safely and effectively as outpatients. And those with more severe symptoms and history require closer monitoring and more aggressive treatment, typically in an inpatient setting. So how can you assess for the safety of an ambulatory withdrawal management plan? Well, the provider should review the patient's substance use history, their medical history, comorbidities, and their history of withdrawal symptoms. And here are some questions that may help guide you. So when considering, can the patient be safely monitored at home? Does the patient have a safe place to stay? Do they have support there? Can the patient maintain telephone-based contact throughout? And does your clinic have the capacity to provide remote monitoring? This is something that may have actually improved during COVID with the ability to do telephone and video visits. Does your clinic have accessibility for patients with alcohol withdrawal symptoms who may need to be seen in person? And can the patient cognitively follow medication instructions and take an oral medication? When considering does the patient need inpatient care, here's some other things to ask. Is the patient at risk of severe or complicated withdrawal? And does the patient have a history of seizures or delirium tremens, hospitalizations for alcohol withdrawal? How severe are their symptoms right now? Are they currently having severe symptoms of alcohol withdrawal? And really importantly, does the patient have acute illness, something else going on medically, or a serious medical comorbidity, or co-occurring substance use that may complicate the picture of withdrawal treatment? Is the patient elderly, medically fragile, and are they pregnant? These are all considerations for inpatient management. Only a portion of patients who stop or abruptly reduce their drinking experience withdrawal. And it's important to try to understand which patient will develop severe withdrawal. A review of the literature found that a history of delirium tremens was the most predictive of this, at least in hospitalized patients. The prediction of alcohol withdrawal severity, or PAUSE, is a screening tool that's used to predict severe withdrawal, and it's been validated in medically ill inpatients. But it does provide some important questions in its questionnaire that I think help as a guide to stratify which patients we see may benefit from prophylaxis or treatment of alcohol withdrawal with a medication. If a patient, if you're considering a medication to treat or prevent withdrawal symptoms, here are your choices. Benzodiazepines are typically considered first line because they've been studied to prevent seizures in hospitalized patients. And you can consider reserving these for patients with a history or risk of moderate to severe withdrawal because of significant concerns for the side effects of benzodiazepines, like delirium, CNS depression, and misuse. If benzos are used, longer acting chlorodiazepine epoxide is preferred because of the steady level of symptom control and the smoother decline that allows for self-tapering that you get with the longer acting medication. For people with impaired liver function or risk of oversedation, like elderly patients, a shorter acting benzodiazepine like lorazepam is preferred. Gabapentin is a newer medication for treating alcohol withdrawal, and it's a reasonable alternative in some cases. It's because it has fewer side effects than benzodiazepines. Gabapentin has been shown in clinical trials to be as effective as benzodiazepines in treating symptoms other than seizures and delirium tremens in the ambulatory setting. So it's best thought of as an adjunct to benzodiazepines or for the treatment of mild to moderate alcohol withdrawal symptoms in lower risk patients. One really nice thing is that it can be continued for maintenance treatment of alcohol use disorder, as we heard about earlier in the talk. The dosing in studies ranges, but it generally settles at about 1,200 milligrams per day that's given in divided doses and tapered over 4 to 6 days. Carbamazepine is another anti-epileptic that can be used if gabapentin is not tolerated. It can be thought of similarly as an adjunctive agent or for lower risk patients, and it has not been shown to prevent seizures. It has more side effects than gabapentin, including drowsiness, pruritus, and drug interactions. And it can be given at around 800 milligrams per day that's tapered over about 5 to 9 days. Next, I'll show you some example protocols. Here's an example of an outpatient fixed schedule benzodiazepine dosing protocol. So patients with very mild withdrawal symptoms, like a CWAL less than 10, can be treated using a symptom triggered approach and only take a benzodiazepine when they experience withdrawal symptoms. Whereas a patient with more withdrawal symptoms can be treated with a fixed schedule like this, which may be simpler and can still offer the option for additional medication as needed. Here's an example protocol for gabapentin. This was developed during COVID, I believe in an isolation and quarantine setting. And I just want to emphasize that there are a range of dosing protocols out there, and a disclaimer that this one starts with very high doses, higher than I've used. So what you can consider is using about 1,200 milligrams per day in divided doses, meaning about 600 milligrams TID or 300 milligrams 4 times a day, that's then tapered over 4 to 6 days. Here's an example of a carbamazepine protocol. And you can consider starting 600 to 800 milligrams in total per day that's given in divided doses and tapered over 5 or more days. Patients who are undergoing this medically supervised withdrawal management in the outpatient setting require very close monitoring plan. So in-person monitoring has become even more difficult during COVID. Though increased telehealth potentially means more ability to engage with patients who are doing this at home. So a patient should be reassessed frequently, even daily, for medication reconciliation and monitoring symptoms using the CWA as your guide. A family member or a close contact can help monitor the patient and dose medications. And if a patient is deemed low risk and you have not started a medication, they still should be monitored, recognizing that the patient may or may not need a medication based on how they do in the first 24 to 48 hours after last drink. If you're worried about a patient's risks or adherence, consider dispensing a limited supply of a withdrawal medication at a time, like every 1, 2, or 3 days. Patients who are at home can also be elicited to help in self-monitoring their own withdrawal using the short alcohol withdrawal scale. This is a patient-administered tool to assess the severity of alcohol withdrawal, and patients can indicate how they felt in the previous 24 hours using this. Scoring more than 12 points indicates moderate to severe withdrawal. Transition to a higher level of care, like an emergency department or inpatient, should be considered if the patient is having any escalating symptoms despite your treatment. If their CWA is greater than 20, the SAWS, the self-administered scale, is greater than 16, and obviously if they're experiencing any distress, altered mental status, or seizures. The duration of treatment will vary depending on the patient's withdrawal symptoms and may last anywhere between 1 and 7 days. And those who drink very heavy amounts daily are at risk of progressing to more severe withdrawal for up to about 5 days after their last drink. During this time, you can recommend to your patient the importance of a regular diet, of eating healthy food, staying well hydrated, trying to reinforce a safe and relaxing environment, and considering a multivitamin containing thiamine and folate during the time of withdrawal. And very importantly, please don't forget medications for alcohol use disorder, which should be offered to the patient after the acute management of their withdrawal. So we're running quite ahead of schedule. And lastly, we'll move into discussing harm reduction approaches. Harm reduction is a set of strategies aimed at decreasing the negative consequences of alcohol use. Patients are not all interested in abstinence or ready to stop drinking completely. So next we will discuss how you can support your patients while they are drinking. And furthermore, we can recognize that even reducing drinking and reducing the harms of drinking has been shown to have beneficial effects for the patient's health. Actually, recent studies have found that reductions in the amount that people drink, including the grams of alcohol per day, actually have shown effects, beneficial effects to blood pressure, to people's quality of life, to LFTs. And when researchers have gone back and looked at the medications that we've discussed, medications for alcohol use disorder, they found that even with drinking level reductions, they've been able to see positive effects of medications. And so many of the medications for alcohol use disorder, as we discussed, are approved not only for the outcome of abstinence, but also for reduced drinking. So here are some techniques to discuss with your patient who is drinking alcohol. Patients can avoid, you can counsel them to avoid mixing alcohol with other substances, especially CNS depressants like benzodiazepines or opioids. People can pre-plan their intoxication or party periods to really try to plan out the circumstances. That means planning a ride, maybe using an app-based ride service. They can bring condoms. They can log out of embarrassing social media or internet that may potentially be embarrassing later in the night. Patients can be counseled to count the number of drinks that they're consuming and pay attention to the size and the content of the drink. They can be counseled to spread out drinks over time in the course of the night. People can even use a pocket breathalyzer to monitor themselves and their level of intoxication, especially before driving. You can help counsel around alternating drinks with non-alcoholic ones, hydrating between drinks, and eating before and during drinking. People can add ice to their drink. And you can counsel your patients that it's okay to continue most prescribed medications if they're drinking alcohol, except you want to be especially careful with sedatives, as we discussed, avoiding CNS depressants along with alcohol, and disulfiram, which would lead to an incredibly unpleasant reaction along with drinking. You will see many patients with unhealthy alcohol use in your primary care practice because it's common and because these patients care about their health. We started the presentation noting the close links between really common primary care conditions and alcohol use. And now we'll highlight how routine healthcare maintenance that we do in primary care is especially important for this population. I think somebody may need to mute themselves. Thank you. For example, screening is important for people who drink, given their increased risk of cancer, falls, cognitive decline, and cardiovascular disease. And heavy alcohol use actually prompts osteoporosis screening before the age of 65. Infectious risks that are increased with alcohol use should prompt immunizations listed here and TB screening. And people with alcohol use disorder are at risk of vitamin deficiencies, as you may recall. And the clinician should assess how the patient's diet is. Do they have access to food? Are they eating regular meals? Have they experienced weight loss or GI symptoms that may indicate malabsorption? Importantly, primary care providers can connect patients with resources for food insecurity if they're experiencing food insecurity and drinking alcohol. The provider can review the medication list for interactions with alcohol. And importantly, we should assess for patients' use of other substances because we know that it's very common to use alcohol along with other substances. The risk of overdose from opioids, for example, is increased when mixed with alcohol. And tobacco has synergistic effects with alcohol that can increase people's cancer risk, driving home the importance of addressing nicotine use along with alcohol use. And lastly, all patients should be offered family planning. We in healthcare can do something else to help decrease harm to patients who drink alcohol by using language that does not further stigmatize our patients. We can use person-first language, meaning a term like person who drinks alcohol rather than alcoholic or drunk. And we can use clinically accurate language. Throughout this talk, you've heard the terms alcohol use disorder, unhealthy alcohol use, and high-risk alcohol use, and you've heard how those are defined. And they can be used instead of terms like alcohol abuse. Remission is a term that can be used rather than sober, and it refers to when a person is no longer meeting DSM-5 criteria for alcohol use disorder, except for that of craving. Remission from alcohol use disorder is categorized based on its duration. Initial remission is up to 3 months, early remission is between 3 months and a year, and sustained remission is between 1 to 5 years. Recurrence is a term that can be used rather than relapse, as relapse is a heavily loaded term for many of our patients. So let's review in summary, and then we'll have about 15 minutes for questions. In summary, screen all adults for unhealthy alcohol use. Use brief counseling interventions for at-risk drinking and prescribe medications for alcohol use disorder. Apply a patient-centered approach to medical and psychosocial treatment selection based on a patient's individual goals and comorbidities. Consider outpatient withdrawal management for patients without a history or symptoms of severe withdrawal. And treat alcohol use disorder even when abstinence is not the goal. So please feel free to reach out with any questions that may come up while you're caring for your patients. You can reach out for teleconsultation with a provider question on our substance use line or any of our other lines. You can call the numbers listed here or submit a question via the website. And the National Clinician Consultation Center is especially pleased to support rural communities where access to local specialists may be particularly impacted by COVID-19. So we welcome your provider questions. Thank you so much. And we'll go ahead and move into the question and answer discussion portion of the talk.
Great, thank you so much, Dr. DeFries. This is Dr. Chu. I have the pleasure working with you here at the NCCC. I was just hoping to help out by moderating some of the Q&A, and I did note that there were a few questions that popped up in the chat box, and I'm happy to mention those to you. And then we also did get a number of questions when people registered, so I think since it looks like there might be time, there were a couple of questions, particularly around potentially co-occurring OUD and alcohol use disorder, and how you, what sort of informs your medical decision-making with those therapies. So in terms of the questions that popped up on the chat box, someone was wondering if you could be a little bit more specific on what your liver dysfunction threshold is as a, either an absolute or relative contraindication to chlordiazepoxide use. And then also if you could go into a little bit of detail on how you transition someone who might be finishing medications for withdrawal into more maintenance therapies.
Great question. So first, let's take the question about chlordiazepoxide use and liver impairment. So that's a really good question. And I'm not aware of a specific numerical cutoff in the liver function that prohibits the use of chlordiazepoxide. But it's something that I would take pretty seriously because chlordiazepoxide and benzodiazepines other than lorazepam, oxazepam, and temazepam all have active metabolites, which stick around in the system when they're not cleared by the liver and continue to cause sedation and many of the adverse effects of benzos that we don't like and that we see actually cause harm in patients. So if there's a patient that has impaired liver function, I would use lorazepam instead as an alternative. And so the function can be seen, markers of function may include the INR, they may include a history of encephalopathy or coagulopathy or ascites. But if you're concerned about elevated AST, ALT even, a hepatitis, I would err towards using lorazepam because protocols exist for the use of lorazepam and it will decrease your risk of adverse effects. And I think particularly when we're managing patients as outpatients, as we're discussing here, and we're not monitoring them face-to-face or necessarily seeing them on a daily basis in clinic during COVID, it seems safer and more conservative to err on the side of lorazepam when you have any concerns about liver function. I hope that that helps. The next question, Carolyn, remind me of the next question.
Yeah, I think it was just to elaborate a little bit on how you might transition someone who you'd been sort of finishing the withdrawal taper into a maintenance medication, and then maybe a follow-up from that. Phil Bolduc added, can you talk a little bit around sort of selection of the medications for AUD? like what, naltrexone versus something else?
Sure. So I think that one of the most important factors when selecting a medication for alcohol use disorder is the ability to actually talk to the patient about it and talk about their preferences. Are they able to take a medication once a day, a pill once a day? Are they up for taking a pill 3 times a day? What are their other medical conditions and comorbidities that may impact our choice? Sometimes in the period of acute alcohol withdrawal, people are uncomfortable. Sometimes, and you're probably used to this if you've seen them in the hospital, they're actually sedated. So it's not the greatest time during acute alcohol withdrawal to engage in that discussion with the patient. And you really want to use shared decision-making and have the patient actually express their preference for a medication for alcohol use disorder. So I would wait until the patient is comfortable and able to engage in that discussion. And sometimes that can happen right after alcohol withdrawal. Sometimes the patient hasn't experienced a serious alcohol withdrawal, or sometimes it may take longer before they feel comfortable enough to have the conversation. There isn't actually necessarily a contraindication or a harm of using some of these medications during alcohol withdrawal treatment. In fact, gabapentin is a medication that you might use for the treatment of alcohol withdrawal and then continue for maintenance treatment of alcohol use disorder. I don't think you'll do harm necessarily by having a patient on naltrexone while they're being treated for withdrawal, for example, but you just want to make sure that you're able to have that conversation with them. In terms of an approach to selecting a medication for alcohol use disorder, I usually think of naltrexone as a first-line medicine. Naltrexone and acamprosate, as I mentioned, are the most evidence-based choices. So I start with those two. And then if a patient cannot receive one of those for an issue related to liver function or opioid use, or the fact that they can't take many pills a day, which is what's required of acamprosate, then I move to my other choices, such as gabapentin.
Okay, great, thanks for that. There are now 2 questions that I'm seeing that are a little new, and I'm wondering if you can elaborate. And so the first one is around, I think, sort of what's the ideal setting for managing someone, and we realize that every community looks very different in terms of resources, but I think it's specifically like, what's your threshold for differentiating if someone may be, safe and appropriate for an ambulatory withdrawal versus when you might really strongly advocate for them to go into a more monitored setting? That's question 1. And then the other question is, if a patient is on multiple medications for alcohol use disorder, but is still drinking, how would you have that conversation or decision around trying something else? Or just, how would that look?
I'll take the second one first of what if a patient is on medications for alcohol use disorder, but they're still drinking? So the first thing I would clarify is, what is the patient's goal? And go back to trying to get a sense of that. Because maybe the patient's goal is not to cut back completely and complete abstinence. Maybe their goal is actually to reduce their drinking. And so maybe you've actually made progress towards their goal by using a medication that is evidence-based to decrease their amount of drinking or their number of days of drinking. So first I would clarify their goals. And then secondly, I would try to get a sense of if the medication that you're using has been effective at all or has been partially effective. If it's been partially effective, there's a chance that you could increase the dose of the medication, or you could combine the medication with another one that has a different mechanism of action. So a good example is a patient is on naltrexone. They're having some benefit from the medication, but they haven't reached their goal of, let's say, cutting back to five days of abstinence per week or something. In that case, things I may consider are actually increasing the dose of naltrexone to 100 milligrams if they have no liver impairment, or combining it with another medication. So you could entertain combining naltrexone with gabapentin, for example. Naltrexone can also be combined with acamprosate or topiramate. These combinations have been studied somewhat and are safe, but don't have a ton of data around them. But it is safe to actually combine medications as well. I see there was another question about combining acamprosate and naltrexone. Something you can do. The other question about how do you actually decide who is safe I'm just going to go back to our slide here because I think this sort of encapsulates my thought process. When I think about who's an ideal candidate for outpatient withdrawal management at home, I would think about somebody who, firstly, does not have a significant risk of developing seizures or severe withdrawal or delirium tremens. And I figure that out really by asking them about their history and doing a review of the chart around their history of withdrawal. If they don't have that history and they're not currently ill or in severe withdrawal, then I think about things like, do they have a place to stay? I take care of a lot of people experiencing homelessness, for example, where this isn't an easy question, but do they have a safe place to stay? Do they have somebody there who can keep an eye on them, who could even help them with their medications? And is this a patient who's able to handle cognitively or just organizationally able to handle taking medications on a specific schedule for a few days? And is this a patient who has a phone, who I can talk to, who can check in with our clinic on a daily basis? Those are the kinds of things that if met, I would consider a good candidate for outpatient withdrawal management.
Okay, great, thanks. I think we might have time for a few more. I'm seeing questions around, can you speak to sort of the prevalence of co-occurring mood disorder, specifically bipolar spectrum disorder, and people with alcohol use disorder or other STDs? And then also, can you just touch on youth? And then maybe if you feel like you've got time, Dr. DeFries, if you can speak a little bit to maybe co-occurring opioid use disorder and how that informs, naltrexone use, probably most obviously.
Mm-hmm. Sure. So co-occurring mental illness along with alcohol use disorder is obviously common. There have been some studies that have looked at the use of antidepressants along with naltrexone and have not necessarily found it more effective to combine those. I am not aware of any specific studies around bipolar disorder and alcohol use disorder. I do not believe that there's any specific contraindication to these medications for people with bipolar disorder. However, I would, monitor how people were doing, and I would see if people are depending on how they're doing, are they in a place where they can manage a once daily medication like naltrexone, a monthly injection like naltrexone, or a medication like gabapentin or acamprosate that might be 3 times a day in the setting of their bipolar disorder. So those are my thoughts on bipolar. I am not very versed as an internist on the specific subpopulation of youth. I am aware of some studies about ondansetron, which is not FDA approved for alcohol use disorder, but has been studied for the indication as being one that has been found to be effective specifically for youth and adolescents with alcohol use disorder. But again, this isn't really my specialty. I don't believe there's a contraindication to using these in adolescent patients, for example. And then I will touch on co-occurring opioid use disorder because this question comes up a lot. And I know we got a couple of questions in preparation for this talk about what do you do with a patient with co-occurring opioid use disorder? Because those patients cannot receive naltrexone first-line medication. So for those patients, acamprosate is an option. Gabapentin is an option, though you want to just be aware of if there's a risk or experience of sedation that may co-occur with sedation from opioids. Topiramate would be in a similar boat. And then there's some select patients who may be using naltrexone actually for treatment of opioid use disorder, like the injectable monthly naltrexone can be used for treatment of both opioid use disorder and alcohol use disorder. It requires a period of abstinence from opioids for around 7 days prior to its initiation. And there's only some patients with opioid use disorder in whom I would consider injectable naltrexone. And I may prioritize something like an opioid agonist treatment for many patients with opioid use disorder, like methadone or buprenorphine. But for a patient in whom you're thinking about IM naltrexone it is a potential therapy for both opioid use disorder and alcohol use disorder together. Any further questions?
Dr. DeFries, there's one from a Vitalia Ngala about sort of around the theme of sort of best setting for withdrawal and trying to, I guess, advocate for an inpatient consideration. I know you spoke, you shared your other slide, but any suggestions or just ways to, I guess, have those types of conversations?
I think there isn't a one-size-fits-all answer for this very difficult question of what is the best setting for your patient to undergo alcohol withdrawal management. And it's something that is so specific to each of our unique settings. Some practice environments have easy access to an inpatient detox or medically supervised withdrawal management inpatient setting, and some places do not. And so those are very, very unique challenges. There's also, differences in our practice settings with regards to how easily we can see patients. I practiced in a rural setting, and I wasn't able to monitor patients who were many hours away and didn't have phones very easily as outpatients. And then we have different barriers to actually our inpatient hospital setting when patients require medically supervised withdrawal. Some places you can admit patients for this, some places you can't. So it's really going to depend on your unique setting, and I encourage you to explore the resources that you do have so that when a patient comes to you, you're prepared to say, here are the different options, and prepared to assess whether they're safe for a potential outpatient plan or you really need to search for an inpatient option. And it may be helpful to engage the patient's family and close contacts in this discussion, as well as other people in your health system who are aware of the resources.
Dr. DeFries, do you want to take one? This was a comment, I think, and from, it looks like a provider in Massachusetts. So the section that is named in the chat is probably specific to the state, but it's basically sort of when you would talk or think about involuntary hold.
Interesting. Involuntary for alcohol withdrawal or for high risk?
For an alcohol or substance use disorder. It looks like specifically in Massachusetts, Section 35 allows for a mechanism for a qualified person to request sort of a court intervention.
Interesting. There's a long history of coercion when it comes to people with substance use disorders and substance use broadly. And, I think as a general approach, I very much try to be particularly patient-centered when it comes to treating people with alcohol use disorder and really value their goals. This often takes a long-term relationship. It often takes, months and years to achieve that kind of relationship with a patient. We hopefully in this audience of primary care providers, we're able to benefit from some of those longitudinal relationships. But I'd say, as a general principle, that we want to prioritize patient choice and patient decision-making around the setting of their treatment and what their goals are, whether it's to continue drinking, stop drinking, cut back drinking. And I don't know the details of that specific section, but it's definitely, I'm sure it comes in the context of a long history of coercion and stigma that people with alcohol use disorder face.
Great. So just want to thank you again, Dr. DeFries, for your time and thoughts with this discussion. I want to thank all of our participants for sending in so many wonderful questions and posing them in the chat box now, and just invite really everyone to feel free to call us on our warm line or certainly navigate over to our website because we'll be posting the recording and the slides there, as well as sharing by email. Thank you, everyone.
Thank you so much, and thank you for your engagement on the chat.